So we're going to be talking about aortic stenosis today. So let me know if you have any questions. So let me just start here. So what is aortic stenosis? So it is a chronic progressive disease. It is a degenerative condition of the aortic valve. It produces obstruction to the flow of the blood from the left ventricle to the left ventricular outflow tract and the aorta. It leads to symptoms mainly of chest pain, breathlessness. Patients can present feeling faint or dizzy, or with syncope itself, and they can be feeling very tired as well. So, if anybody presents to you with shortness of breath, always look at their age, have a listen at their heart as well, and just try and keep aortic stenosis on one of the differentials because it can present in younger patients as well, especially if they have a bicuspid aortic valve. So not every breathlessness is respiratory. So just moving forward, so just looking at a bit of statistics here regarding to aortic stenosis. So the incidence and the progression of the degree of stenosis obviously increases with age. 1 to 2% of people who are 65 years and older, and 12% of patients 75 years and older, they have a calcified aortic valve. So it doesn't mean that it's obstructing the flow. It just means that there's enough calcium deposit on it to start the sclerotic and then the stenotic process. And the older we get, so let's say if we're above 75, 3.5% will have severe aortic stenosis. So it's not a great number, but it is significant enough to cause symptoms which can lead to heart failure, myocardial infarction, as we'll discuss later on. Now, sclerosis is the beginning of stenosis. So that's when this calcium deposit on the valve, it starts getting thicker and tighter. And if there's sclerosis without stenosis, it means that there's very irregular thickening of the calcium. So the calcium will keep getting deposited above the valve, below the valve on random areas. And then the age, obviously, it ranges from 9% with the mean age of 54 years. And then as we grow older, so for instance, if someone is in their 80s, half of the patients in their 80s are likely to have some degree of aortic sclerosis. The rate of progression to stenosis is around 2% per year. It's not massive, but if you do end up having stenosis, then you will need monitoring and annual echocardiograms to see the progression and then see what symptoms you're having and then subsequent treatment. Any questions so far? Okay, we'll move forward. So as you can see, this is the aortic valve. On the left, there's a normal aortic valve, and then on the right, big B, we can start seeing calcium deposits, and then you can see how it starts, the aperture starts narrowing. So this is how it progresses. Etiology. Now, we can have age-related degeneration and calcific deposits, which is seen out of degenerative aortic stenosis, which is the most common cause, no rocket science. And then you have a congenital bicuspid aortic valve. Just recently, I had a patient. He's 25. He was diagnosed with bicuspid aortic valve by a GP echo in 2023, but I think that echo was not followed up, and then I think he went to hospital because he was unwell with something else, and then there were some cardiology trainees there who did his echo just for their own logbook, and they found that he's got a bicuspid aortic valve, and then he's been so anxious since then. So I think it's important for patients to be informed of their diagnosis, but also to reassure them to some extent that bicuspid aortic valve does not always mean that they would end up getting a valve replacement. It's more common in the younger patients, but that they do need follow-up under cardiology. So there's fusion of the right and the left coronary cusps in 79.3% of patients. Now, it's associated with Turner syndrome, coarctation of aorta, Sean syndrome, and complications are you can get infective endocarditis, aortopathy, and 10% it's present in your first degree relatives as well. Okay. It can also be present with ankylosing spondylitis and connective tissue and autoimmune conditions. And then the third cause of aortic stenosis is rheumatic heart disease. So, rheumatic heart disease commonly in the third world countries, it tends to affect your mitral valve. It's more prevalent there, but it can also cause thickening and fusion of the aortic cusps and lead to aortic stenosis. Okay. So then there are two types of aortic stenosis. There's subvalvular and supravalvular aortic stenosis. In subvalvular, I've tried to put a little echocardiogram window here. You don't have to worry about it. It's basically circumferential thickening of the aortic aperture, but it's below the aortic valve. And what happens is that when the blood tries to get in systole, when the blood is trying to move out of the left ventricle, there's a high velocity jet across the outflow tract. So at that point, the valve is still okay. It's just under the valve that the stenosis and the calcium deposits have started. It can be accompanied by aortic regurgitation or sometimes an anomalous mitral valve tissue as well, called a hammock or a parachute mitral valve. So these are some findings you would see on the echocardiogram. Supravalvular aortic stenosis is obviously above the aortic valve, as it's self-explanatory. There's obstructive narrowing of the aorta just above the valve, and it's uncommon. It can happen as part of Williams syndrome as well. Okay. And then on the pictures, you can see that there's a discrete hourglass shape or a tubular shape of the aortic valve. Now, what are we worried about in aortic stenosis? I'm just going to pause here. Any questions at all? Let me just have a look at the chat. Okay, fine. So I'm just going to now move forward then. So in aortic stenosis, what is the main mechanism of flow obstruction? It's called LVOT, basically left ventricular outflow tract obstruction. What happens is it gives to rising pressures in the left ventricle. It gives rise to not only your systolic pressures, but the heart does not relax fully during diastole, and that gives rise to diastolic pressures as well, right? And it increases the left ventricular endometrial thickness as well, because when your left ventricle is constantly trying to push blood across a tight aortic valve, the endocardium, the myocardium, they all start to proliferate and get thickened. Okay. All of these dynamic situations will lead to increase in your LV mass, LV hypertrophy, and ultimately heart failure, LV dysfunction, because your myocardium is constantly under shear stress of working under high pressure, high flow conditions. It increases the oxygen supply of the myocardium. Okay. When there's impaired diastolic dysfunction, we know that our coronaries, they get perfused during diastole. If there's a bicuspid or a stenosed aortic valve, the diastolic filling pressures are affected of the coronary arteries. That can lead then, as you can see, to myocardial ischemia, ultimately heart failure, or vice versa. Okay, so these are a few commonly found complications of aortic stenosis. So I'm just going to move forward now. So in this little graph here, you can see the older we get, the trajectory or the survival rate decreases exponentially. So there is a latent period when we're a little bit younger. There's calcium being deposited on the aortic valve, and then that ultimately increases the obstruction, increases your overload, myocardial overload, and then suddenly one fine day the patient is going to start declining very quickly. And that happens the older we get. The survival rate reduces proportionally. But we can get angina, syncope, and heart failure. These are the three common symptoms. And the older you get, your survival rate automatically reduces. excuse me, it can cause sudden cardiac death, GI bleeding as well. Does anybody know why there is an association between aortic stenosis and GI bleeding?
Hyde syndrome?
Hyde syndrome, exactly. Hyde syndrome. So there's an acquired von Willebrand disorder. So when your blood is being forced against a tight aortic valve, von Willebrand proteins are formed, and then they can basically cause stress in the arteries and vessels in the GI tract, and that causes angiodysplasias, bleeding, and so on. Okay. There's endocarditis as well, arrhythmias, obviously VT, AF, VF, and embolic events are common. So when you are going to be presenting, obviously, or be preparing for your PACES exams, or if you have already done PACES, you're probably aware of some of the findings and the type of pulses that are present in aortic stenosis, such as the anacrotic pulse, pulsus tardis. I'm not going to go into the detail. This is a lot. It's very wordy, and carotid shudder as well. Okay. There's relative hypotension. There's a narrow pulse pressure. Apex beat is sustained, and it can be displaced. There's LV hypertrophy, but usually it's non-displaced initially. And there's a thrill, okay, over the right second on intercostal space. You can sometimes find an S4, S3, especially if the patient has developed symptoms of heart failure. There's a soft A2. Sometimes you can get paradoxical splitting as well, and a later peak of crescendo. So normally it's a crescendo decrescendo murmur, but in later on, the worse the stenosis get, the crescendo peaks more. Okay, and eventually the murmur is not loud; it gets softer. Okay, and sometimes it disappears as well. Gallagher phenomena is when this calcific aortic valve, the systolic murmur is loudest, not at the aortic area, but more at the base of the heart, basically. And sometimes we can mistake it for mitral regurgitation as well. That's just to simplify it. And that's just to do with the dynamic and the blood flows and the hyperdynamic situation of the aortic stenosis. Right. Any questions so far? Okay. Uh, so we will start with baseline tests. Basically, you hear a murmur, you think it's aortic stenosis, patient is symptomatic, sort of older age, even if young age patient, you're going to do an ECG, chest X-ray. Can anybody tell me what we would find on an ECG in aortic stenosis?
Left ventricular hypertrophy.
Yes, exactly. The more stenosed the valve is, the higher the LV pressures you can get left ventricular hypertrophy eventually. But it can be normal as well sometimes. Chest X-ray, you're going to do an echocardiogram. Sometimes we do exercise testing as well. And then obviously we need to do a cardiac catheterization. And the reason for that is if we are working patients up for a TAVI, or if they're younger, if you're working them up for a metallic AVR, then we want to make sure that their coronaries are okay. Because if you are going to open up the chest and put in a metallic valve, why not at the same time do a bypass graft as well? So we do a catheterization. We also do catheterization to study the flow across the LV valve, the pressure gradients, and so on. Then you can do CT imaging as well to look at the because we do echoes, but CT gives us a better idea of the anatomy of the stenosis, or the extent of the stenosis, and the anatomy of the valve, because that helps us determine what type of or what size of valve would be needed later on. Okay, and also for calcium scoring. And then we can do CMR and PET as well, which is a cardiac MRI. ECG, like we mentioned, shows LVH with strain. You can get left atrial enlargement as well. When your left atrium is being enlarged, that is a substrate for AF. So a lot of patients with AS will have atrial fibrillation as well, or atrial tachycardia. Okay. Sometimes on the chest X-ray, you can have either normal heart size or hypertrophy can cause cardiomegaly as well. Okay. So just to simplify the echocardiogram, because that is pretty much what we use initially to ascertain the severity of the AS, is we look at three things. We look at the peak aortic velocity, which is how forcefully the blood is being pushed across the aortic valve. We look at the gradients, the pressure gradients across the valve, the pressure gradients of the blood flow. We look at the peak gradient and the mean gradient and the aortic valve area. Okay. Now, we use multiple acoustic windows. Peak velocity, if it's above 4, it's severe. And that's when we start thinking about working patients up for TAVI or aortic valve replacement, metallic aortic valve replacement. Similarly, mean gradients, if it's above 40, it's severe. If it's 60, it's very severe. Okay. And aortic valve area as well. So that's another dimension we look at. Okay. So I'm not going to go into these details because it's got lots of echocardiographic details in it, which I don't think are needed at this stage. But anything which is less than 1 centimeter is considered severe, and it's less than 1 point. If the area is less than 0.7, then it's critical aortic stenosis. Initially, we can manage patients medically. Can anybody tell me what sort of medications we shouldn't be given to someone with aortic stenosis?
Beta blockers.
Beta blockers are the treatment of choice.
Okay,
So
you mean
what should we avoid?
ACE inhibitors should be contraindicated.
Yeah,
Or
they're not absolutely
GTN.
contradictory. Sorry.
GTN.
Yeah, nitrates. Nitrates should not be given. And then yes, the more severe it gets, we should avoid ACE inhibitors as well. That's correct. So medical therapy is obviously making sure that the patient's pressures are well controlled. You can give them beta blockers, calcium channel blockers, and then you also have to follow them up annually. If aortic stenosis is severe, then more closely you have to monitor them, let's say 6 monthly, and because then you're trying to work them up for TAVI or metallic valve replacement. So the timing of intervention is basically directly related to your echocardiographic findings as well. And then obviously the choice of intervention depends on the age, the comorbidities, and if you want to do surgical or tissue valve replacement. There were certain trials, the partner trials, SU-TAVI trials, and these are a couple of trials which have been going on, such as the recovery trial. These trials talk about the mortality benefit, the mortality and the choice of valve and how one is preferred over the other. So this, I don't think you need it at this stage, but it's just something because if you're appearing for your cardiology ST for interviews, you might be asked about these trials. So there's partner A, partner 2, partner 3, evolute, and recovery trials. Okay. Any questions so far?
Can I ask what's the cause of LA dilatation in aortic stenosis? Is it a back pressure or what exactly happens?
Yeah, it's back pressure. So basically, what happens is that because your this outflow tract obstruction, the blood is going to go back into via the mitral valve into your LA, basically, and
Okay.
that's what causes LA dilatation. Yeah, yeah.
Okay, thank you.
You're welcome. Anything else? Okay. So post-procedural issues like with any valve surgery, any open heart surgery or transcatheter valve replacement, you need to follow the patients post-operatively. There's that period of recovery where they need cardiac rehabilitation. And obviously, rehab is important because it helps patients build up their exercise tolerance. It gives them awareness of their situation. We can check their compliance to medications and just generally their well-being, and that automatically reduces your risk of complications post-op and risk of rehospitalization. What else? So valve thrombosis can happen, especially if you've had infections. For instance, if you've had discitis, you can get valve infections, or any infection can affect your prosthetic valve, whether it's a tissue valve or a metallic valve. Okay. You can get valve thrombosis. So, for instance, if you have a metallic valve and you're not taking your anticoagulation properly, or if you're subtherapeutic in your INR, then obviously your risk of thromboembolic problems. And then the leaflets can sometimes tear. It's if it's a tissue valve, and then there's a life of metallic valves as well. So they just need replacement if they've been in. Some metallic valves are very long lasting, but if they've been implanted earlier in your life, then obviously they can end up getting stenosed and need replacement. We do not give DOACs in metallic valves. Always warfarin is the choice of anticoagulation. Thank you. So that was just a brief overview. If you have any questions, please let me know. We do have a lot of time in our hands still. If there's anything regarding upcoming exams, I'd like to know anything at all.
I do want to ask, like, I always struggle with picking up the metallic heart sounds. Is there any maneuver we can do or anything like that?
So, metallic heart sounds.
Yeah,
Okay. So it depends. So if you have a metallic mitral valve, right? So you're going to hear a metallic first heart sound. Okay.
yeah,
Uh, and the way you feel heart sounds or auscultate, sorry, heart sounds is by sort of pressing your carotids, and then
yeah.
where you feel that first impulse, that's your S1. Okay.
Mm-hmm,
When the carotid pulse falls, that's your S2. Okay. So
mm-hmm.
you have to time it. Have you heard any audios online that would help
Yeah,
you? You have, okay.
yeah,
It's all going to come with practice. Again, the trick is you put your ear closer to the precordium, you can hear a metallic click. You put your stat on the precordium, and then you try and see where the click is loudest, what heart sound it's corresponding to. But sometimes it can be tricky
yeah,
because patients, when I teach on the bite basis course, I have a patient who has two metallic valves. She has
mm,
aortic mitral valve. Then I have one with just an aortic valve, and candidates say it's a mitral valve. So for the PACES exam, you don't have to sweat yourself too much as long as you're picking up. It can be difficult, it can be tricky, it's not easy. As long as you're picking up, it's a metallic click, not a prosthetic valve. As long as you're not missing a murmur, you won't be prosecuted or failed for not being 100% precise. You just have to be sensible in your findings, and the examiners will then automatically lead you towards what they're trying to find out or what they want you to know. So for instance, it's a metallic mitral valve and you said it's an aortic. I think it's an aortic valve. That's fine. You heard a metallic click. The examiners will automatically viva you. Okay, tell me, what are the causes of mitral valve mitral stenosis? You'll say, oh, rheumatic fever, etc., etc. So you don't have to worry so much about it. But yes, if you listen to YouTube videos, if you have any patients on the cardiology wards, okay,
yeah.
yeah. And when I was doing my paces, I used to go to different hospitals
All right.
where my colleagues were, and I used to go in their cardiology wards and have a listen, because I we used to have only, because metallic valves are not very common on the
Common.
cardiology wards.
Yeah.
So for hospital. Okay.
Thank
And
you.
I have I have another presentation I was making for another group of candidates. I do, it's half prepared. I do apologize, but I can see if I can bring up some. No, that's not the one. Sorry, my computer is very slow today. Yeah, this. So because I have a few, maybe we can listen to a few audios basically. So let me try and close my presentation and then I'll share this one. So how do I stop sharing? Stop share. Sorry, I'm not tech savvy at all, as you can clearly see. Okay, let me just close this. Let me see if I can get some audios for you, and then I'll say share. Where is the share button? Yeah. Okay, so let's see if we can design. So how do I slideshow? Okay, let's see if I can. So this is mitral stenosis. So basically, you will hear a rumbling, a growl and a bark sound, typically a rumbling, low pitched crescendo, but it will be through diastole, right? So let's have a listen again. That's your mitral stenosis. Again, very difficult without you having your hand on the carotid, but let me just see. So that's stenosis. Then there's Austin Flint murmur as well. So that's done. And then let's aortic regurgitation. Let me just play it from the beginning. Slapping S2 sound, and then there's a blowing murmur with it. So it's very difficult, I mean, just to have a listen and differentiate. It's more about practice, basically. So I apologize, the presentation isn't 100% because it wasn't meant for you guys. But that's just from some of the few sounds. Let's see, there's something in the chat here as well. Can I read this out loud? My last exam, I had a case of a middle-aged Caucasian female. She had a central sternotomy scar, metallic click corresponding with second heart sound, okay, supraclavicular scar, and a cardiac device. She also had a leg vein harvest scar. Okay, I identified all components and presented the case with confidence, AVR cabbage. I have differentials which were broad, including degenerative causes and bicuspid aortic valve or maybe valve repair secondary to infective endocarditis related incompetence. My feedback was that you didn't say patient had Marfan's as overarching diagnosis and I was poorly marked for the station. It was a complete shock as I knew Marfan's is common but in room or consult cases not as a pure cardiac station. Well, I'm sorry that you've had this upset. Oh, you couldn't hear the murmurs. Oh, I'm sorry. I can, if you guys, I can share the presentation with you if you want. If you tell me how I can share it with you guys, if I can put it in the chat, then I can give you my presentation. That's fine. Sorry, Raisa, you had this experience. So what do you think retrospectively that the patient had Marfan's? Did they have any features of Marfan's? Were they tall? Did they have a high arched palate? Okay, so they had Marfan's. Well, I think the examiners were then being very not unfair, but a bit too tough on you.
Um,
Um,
Sorry, Dr. Malik, if it's okay for me to speak.
yeah, please go on. That's
Yeah,
better.
no,
Yeah.
I was just thought I'd share my experience because when you're speaking about metallic valves, like I
Yeah.
had examined many cases in the cardiothoracic wards with both aortic and metallic, and I seemed to be rather confident to identify them. But in my exam, when the 6 minutes was a pure cardio station, and I had a Caucasian middle aged, maybe in her 50s, female who was fully covered head to toe with blankets, and I obviously didn't do any rheumatological assessment or check her palate or check her arm span. It was very it didn't even cross my mind she could have had Marfan's. And in my feedback, when I asked, they had written that although candidate very correctly identified all obvious signs and correlated them to what she individually thought, but she couldn't overarching diagnosis as Marfan's was missed. So my differential diagnosis and clinical judgment was marked as borderline. So I was in complete shock that, as a cardio station, this is some level of expectancy we have as IMT3s. So I just thought I'd share my experience.
Yeah, no, thank you for sharing your experience. I'm sorry that you've had this setback, but I mean, borderline because you missed Marfan's, but you got the diagnosis correct. It's I think they were being a little bit too harsh on you personally, because I passed paces in my second attempt, and I know that marking can be a bit too strict sometimes, and it doesn't make sense. Um, we do have patients with Marfanoid features in the bite paces course as well, and I do emphasize patients to, the thing is, you don't want to give them any excuse, do you? But yes, again, it's a little bit of bad luck as well, I would say. But if you look at the high arched palate, if you think it's a youngish middle-aged patient, then you can say, can you just, while they're sitting in bed, can you just move your arms like that? Just make a rough assessment. Obviously you won't have time to measure the arm span to the height ratio and all that, but I would say that just do these extra little steps if you have time. I don't think you should have failed the station if you missed that. I'm sorry, but I would not have personally failed you on that, because the examiners could have redirected the Viva and asked you what you know about Marfans. It's just one of those things. But yeah, any other experiences, guys, that you want to share? Could you share on WhatsApp by Basis community? How do I share? Right, let's see what I can do. How do I attach this slide for you guys on Zoom? Can I attach it here? Mm, screenshot file. Yep, got it. My computer. Any other questions? Any other experiences? We have a bit of time on our hands. Anybody wants to ask me any questions at all? Uh, I can't attach my presentation in the chat for some reason. I'm sorry about that. What I can do is I can send it to Shoaib and then ask him to send it to you guys. Or if there's any other way you want to tell me how to send it to you now, I'll be more than welcome for any suggestions. But I can't seem to attach it directly from on the chat. Right. FAM is saying on some resource and not others, indication of AVR for AS and AR include LVF less than 50%. Is this accurate? No, not always. I mean, it depends on the aortic valve area, like we discussed. It depends on your AVA, it depends on your peak velocity. It doesn't always depend on your left ventricular ejection fraction. Sometimes aortic stenosis murmur is heard all over the chest, maybe because the person is so slim. Would it be correct to mention Gallaudet in that case? No, please don't mention Gallaudet phenomena. You're going to complicate things for yourself. It's just for your knowledge when you're consultants and professors. Uh, but don't mention anything too complicated, because then the examiners can catch you out on it. You're welcome. I'm not sure if you are on any WhatsApp group for bite paces. Because if you let Shoaib know that you want my presentation, that's fine. I'll send him the murmurs presentation. One day bite basis course. I think it's a It's the more intense one. We've got a lot of patients, and then you go around in pairs, one pair per patient. One examines the patient for 6 minutes, then we viva you, and while we are conducting the viva, then the other candidate will do a quick focused examination. We don't use nitrates because it reduces your afterload. That's the reason, and it's going to cause syncope across the stenosed aortic valve. That's the reason we don't use nitrates, because nitrates cause vasodilation. So nitrates are contraindicated in aortic stenosis. Yes, so the morning of the bite paces 1 day course is not a mock, it's a routine examination. But the afternoon we do a mock, and now we've got marking sheets which are similar to the actual exam. So that's pretty good for you, because we mark you as you would be marked in an exam, and the marking sheet is similar to what the Royal College of Physicians publishes basically for the examination. Third day ends on Saturday. We do Thursday, Friday, Saturday, and then Sunday we do communication skills online, which is your consultation stations. No, I don't think we're giving out any pre-course materials. No. They shouldn't be on ISMN if they have aortic stenosis. Question is, are they having angina because they have aortic stenosis? So the beta blockers is better. Even for angina, first line is beta blocker or calcium channel blockers. It's never nitrates. I would not give a patient nitrates with aortic stenosis. It depends, Kai. I mean, if they have aortic stenosis and had an MI, the question is the aortic stenosis stenosed enough to causing them angina? I would avoid GTN by all means, and go up on the beta blockers, because bisoprolol we can go 10 milligram license dose, but in cardiology we do 20 milligram beta blocker bisoprolol as well off license dose. I mean, if it's mild aortic stenosis, in some cases patients still have GTN in hand, if they have some level of coronary artery disease. But I think your AS is only going to progress, isn't it? So advice it is to avoid it. Then moderate, I would not give it at all, moderate and above. Any other exam experiences that you can share with the team? That will be grateful. 2 more minutes and then we'll sign off. You can also get patients of HOCM in the exam. Always make sure you do your maneuvers. Ask them to strain, do the Valsalva maneuver, or ask them to stand up if you have any doubts. So the patient common cases you will get is uh, metallic valves, HOCM, marfanoid features. What else? We have we do get TOF as well with pulmonary valve replacement, tissue pulmonary valve replacement. You can get tetralogy of Fallot. Young patient, think congenital heart disease. Older patient, look for vein harvest and graft size. Just try to make sure it's not ischemic heart disease with a valve replacement. So yeah, so these are the common cases you would get. Okay, thank you guys. Have a good evening.
Thank you.